Assalamu alaikum. Today we are performing Percutaneous Cysto Lithotripsy for a patient who is 65 years of age and he presented with severe lower urinary tract symptoms and hematuria and was diagnosed to have a 6.5 to 7 centimeter stone in the bladder. You saw the X-ray KUB and now the CT KUB. There is a multiple stones in the left kidney as well, and it showed hydronephrosis and thinning of the parenchyma. So our plan was to perform a cystoscopy, and on cystoscopy we found that there is a big stone, and you can see that the bladder neck is wide open, the prostate is not enlarged. So we under vision performed a percutaneous puncture past a guide wire and then a facial dilator of 6 FR, and over that dilatation we placed an olive tip dilator or that serial dilators of metal, also known as the Elkins dilator. They are passed serially, and after placing the largest metallic dilator, we place the implant sheath, and now we can go with a standard nephroscope suprapubically into the bladder, and we can use the pneumatic lithoclast to fragment the stone into smaller pieces and then remove it through the implant sheath. This will obviate the need for an open procedure, which would include a bigger incision at the skin, and then opening of the muscles, and then cutting or dissecting the bladder. And after removal of the stone, we will have to stitch the bladder and then close the incisions. So it means that it is a minimal invasive procedure as compared to the open procedure, and it can be performed through a 26 or 28 or even a 30 FR implant sheath. So that is how we start breaking the stone, and once the stone has been fragmented sufficiently, they can be extracted through the percutaneous tract in the implant sheath with the graspers. Graspers can be used a two-pronger grasper or a three-pronger. Remember not to break the stone into very small pieces, because the more pieces there are, that many times you have to go in and retrieve those pieces, and the smaller pieces are difficult to grab, so they should match the size of the implant sheath. The good thing in this procedure was that we made the tract under vision, avoiding any injury to the bladder or the perforation of the gut or anything else. And the second good thing, having a flexible cystoscope in the bladder, was that there was continuous irrigation or influx of fluid into the bladder, which was keeping the bladder distended for us, so we could easily make the tract. Here you can see that, as I was mentioning earlier, the larger pieces are easier to grab and remove as compared to the smaller pieces. Here we are using a three-pronger forceps. The problem with the three-pronger forceps is that usually you will be able to see the two prongs of the three-pronger, but the third prong can usually be missed, and that can grab the tissue or the mucosa, which may lead to injury and thus bleeding and poor visibility. And once the visibility is poor, the rest of the procedure becomes extremely difficult. So once many pieces are removed, the larger pieces are remaining, you can use the pneumatic lithoclast again to fragment them and remove them. In this case, we perform percutaneous cysto lithotripsy or cystolithotomy, And we also placed a left-sided DJ stent, and in a matter of 4 weeks we came in again and we performed a percutaneous nephrolithotomy on the left side, and then the stent was removed 3 weeks after the PCNL. So both the procedures were performed minimally invasive, and the patient's age was 65, but he seemed to be older with comorbids as well. So he tolerated this procedure very well. And remember, one of the dreadful complications of vesical lithotomy or open procedure is a contracture of the bladder leading to small capacity bladder later on. So that can be avoided with a minimally invasive procedure. It can be performed under spinal anesthesia, and so on. So now you can see only a few pieces of stone are remaining. A powerful wash with a 60 ml syringe can also clear these small pieces. Because of the movement of the stones due to irrigation fluid, it is difficult to grab these stones. However, by the end, the procedure was a success, and all the stones was removed. And then we place a per urethral catheter and a suprapubic catheter as well. The suprapubic catheter was removed on the second post-op day, and patient was discharged the next day. And the per urethral catheter was removed after 7 days. So this catheter was passed just to be sure that there is no stone in the urethra, because a lot of pieces were here and there. You can see that the whole pot is full of stones. And now we go per urethral and we see everything again. The stent has been placed and the bladder is good. Thank you very much.